don't know if you can see that. Okay, so hypovolemic, cardiogenic. What else?
Distributive.
Neurogenic. Septic. And anaphylactic. Okay, so what do these all have in common?
Shock.
They're all shock, okay. You can do better than that.
Is it a perfusion issue?
Perfusion, right. So decreased perfusion.
Yeah, temperature could be high or low.
Temperature, yeah, high or low. So we're gonna just,
Decreased cardiac output.
okay, decreased cardiac output. You know what, I'm not gonna put that though,
Okay.
because I wanna keep it real simple. Vasodilation. Decrease oxygenation at the tissues, right? And then it leads to multi-system organ failure or disorder, whatever, yeah. Oh, I didn't, multi-organ, hello. Multi-organ system failure, whatever, okay, so, and then once you, I don't know remember the exact percentages, but every organ that you add is 10 to 20% mortality. So if you've got like 3 organs, you're looking at 50%, maybe a little more mortality rate. So if you've got an intubated patient and they have low urine output, that's already 2 systems. And then, you know, because it's hard to recover once they all kind of start going downhill. So that's what they all have in common. So then we can identify the specific things for each shock. So what we want to do is we want to go, what's the cause? And then what's the treatment? I had something else in my head, but it went away. That's okay. Okay, so what's the cause of hypovolemic shock?
Fluid loss. So fluid.
Okay, so fluid loss.
Blood loss.
Okay, so bleeding. Things like the patient was found down.
It's like a car accident too. Well, that would be like.
Car accident, trauma, that's all gonna go with bleeding, dehydration. So if you get a patient that's had surgery, so a post-op patient, most always post-op patients are dry because they were NPO for, you know, a certain amount of time. They had, unless they're having like a really focused surgery like on an extremity or something, if they had any open cavity for a while, you lose about 500 mLs an hour through evaporation. And they don't put that on the report. They do put the estimated blood loss, which is usually underestimated. But it's pretty safe to say that the patient is probably dry. So that's kind of where you would start. So these are all kind of common things, okay? So how do we treat hypovolemic shock?
Replace fluids.
Okay, so fluids.
Blood.
Blood. That's pretty much it. What kind of fluids? Normal saline
Lactated ringers.
and lactated ringers. That's it. Okay, what about cardiogenic? What kind of causes or patients?
Acute MI.
Okay, MI?
Would that one be the tamponade?
Pulmonary embolism?
Could be tamponade. I don't know about pulmonary embolus. It could, I suppose. Yeah, pneumothorax maybe. So cardiogenic is, if you think of the heart as a pump, it's the pump's not working. So whatever causes the pump to not work. Okay? So if I'm taking an exam and my patient has just had a heart cath, or they have an elevated troponin, anything cardiac, my first thought is cardiogenic. Could it be hypovolemic? Yes. I was talking to Gabby about this today, and her patient is post-op, but also cardiac. And so we were talking about how it could have been hypovolemia. That's where we would start because they were post-op. But because they were overwhelmingly cardiac and it had a heart cath and open heart surgery, et cetera, that this is more likely. And so you want to look at all the information to kind of differentiate between the two. Yes?
So the same thing, my patient, he had cardiac problem,
Mm-hmm.
and then lactic acid was high too. So would it be like sepsis if I would, that's why I
Okay,
was
so
asking.
that's a good question. So the question was, my patient had cardiac issues going on, but they also had a high lactic acid. So lactic acid, though it is something we use in sepsis, most commonly sepsis, it's a byproduct of anaerobic metabolism. So if I have decreased perfusion to the tissue, I'm going to get lactic acid. Okay, so it could be any of the shocks for a prolonged period, not just sepsis.
Because the patient was on Levophed, so if they are on Levophed, it will be special?
So Levophed is usually for sepsis. Do we have bands or white blood cells?
White blood cells were ready.
Because bands are usually what we do, or what's the real telltale sign of sepsis. So, though up until probably last semester, third semester, one thing means, like elevated white cells means infection. But now we know that's not necessarily true. Elevated white blood cells could just be inflammation. So we're going to take all of our information and put it together. So if they have lactic acid and they have bands and they have white blood cells, okay, now we're going to look, is there a source of infection? Then yeah, they're probably septic. Okay? All right, so how do we treat cardiogenic shock? Oh, yes, sorry.
So if somebody, like, thinking about my patient, because they were not sure he might have endocarditis, so could that, because if there is a bacterial infection?
That could be the cause of the sepsis, the endocarditis, for sure. Yeah. Okay, so how do we treat cardiogenic shock?
Depending on what it is.
How about the easy one, the tamponade? How do we fix that? Pericardiocentesis, right.
I could not say it.
Between all of us, we'll get the whole word. Pericardiocentesis. So they're gonna poke a hole in there and get the blood out, right? Okay, and then what about, and pneumothorax can lead to tamponade. That's really where that's at. What about the MI? How do we treat MIs? So they have an MI and their heart quits working very well.
Medication.
Okay, so we can give medication. What kind?
I forgot what it's called.
Your patient comes in with an MI and the heart is no longer pumping well. So this is more general. So we only give like amiodarone and dysrhythmias if you know what their dysrhythmia is. Just because you've had an MI doesn't mean you're necessarily going to have a dysrhythmia, right? So it could be a beta blocker, it could be like a positive inotrope. It could be an intra-aortic balloon pump. It could be a heart cath. Yeah, cabbage. Impella goes with this. Okay, so things that decrease the workload of the heart. I think I've said that about 100 times today, and it will not be the last. Anything cardiac, that is your goal. Decrease the workload of the heart, and we can do it with medicine, we can do it with machines, but that is our goal. Because if our heart is working too hard, it uses up too much oxygen, and when you don't have oxygen, you die. Cells die, and then we go into a downward spiral. Neurogenic.
Spinal injury.
Yeah, anything neuro. So anything with your spinal cord, it doesn't necessarily have to be an injury like a trauma. It could be post-op. They went in and had a decompression of their spine or a laminectomy or something like that. It doesn't necessarily, or it could be an epidural. You know, they had an epidural for something else. So anything that is neurological in nature, if they have signs of shock, then it's probably neurogenic. So anything neuro. So when you're taking a test, you want to think about, why is the patient here? Okay. How do you treat neurogenic shock? Hmm?
By paralysis? So they don't go in.
Yeah.
The same as.
If you have injury to your spinal cord, what's going to happen in your body? What happens if I have surgery and something gets nicked in my spinal cord? What is the body going to do to try to fix it?
It's gonna, all the fluid shifting, shunting to the.
Okay, so you could have fluid shifting. You're going to have an inflammatory response with any kind of injury, right? Or infection or whatever. So all of your white blood cells, your fibrin, your platelets, everything is going to go to that area of your spine or, you know, wherever the injury is. So if you have all that inflammation, that's going to pinch, right? Things get inflamed, tissue gets inflamed, and it pinches something, which is what causes the problem, right? So how do you treat inflammation that's pinching something? Anti-inflammatory.
Corticosteroids.
Anti-inflammatory. Okay? The only other thing would be to take them back to surgery or, you know, repair what's been broken. We don't see neurogenic shock very much. There is one telltale sign, other than this is why they're here, that tells us neurogenic shock. There what decreases?
The temperature decreases?
They're cold.
No, we'll talk about signs and symptoms in a minute. We'll come back to that. Okay, septic shock causes infection. So we know all the usual stuff. They've had a cut, they've had surgery, that kind of thing. So injury, surgery, anything GI, because there's poop in there, right? Down. So these are all the septic kind of things. Sepsis,
Respiratory, like ARDS or anything for
it would be pneumonia.
pneumonia?
Pneumonia would also be there, right? So sepsis is one of the most common things that you're going to see in the hospital. You're going to see everywhere. And septic shock isn't necessarily a bad infection. It could just be an infection that the body can't tolerate. It can't, deal with.
I saw lots of them with the older people, the pressure ulcer, it opens the wound.
Right, so yeah, geriatric population, open wounds, things that don't want to heal. And I've seen a lot more use of the wound vac on standard things. It used to just be a gnarly wound that wasn't healing. Now I've seen it we saw it on the open heart, but I've seen it on post-op abdomen. I've seen it all over the place where we normally wouldn't have used it. But it pulls that granulation tissue and it helps stimulate healing. So for sure, any of those kinds of key things, wounds and, anything with drainage. Okay, so those are all septic things. How do we treat sepsis?
Hydration.
Antibiotics, hydration,
Fast timing,
and what?
like fast timing.
Acting quickly, yeah. That would be for
Just for all shots.
all of them.
Yeah.
Mhm. What else? Levophed, norepinephrine. We used to say Levophed, leave them dead. And because it vasoconstricts everything in your body, including all of your little capillaries, and your feet and your hands will turn purple until they fall off or you die. But now we know that when used for sepsis specifically, it can be very, very helpful because it just vasoconstricts. It's not a cardiac drug, okay? You also might see neosynephrine or phenylephrine. They're all kind of the same thing, but norepinephrine is the one that we're using most commonly. So it's funny that in my career, we started with Levophed, leave them dead. We didn't have anything better though, so we were still using it all the way till now. It's like treatment of choice for blood pressure support in sepsis. It's very interesting. Okay, and then anaphylactic shock causes. Allergies. Who has a lot of allergies? Like kids, like you've learned this in peds. There's a diagnosis they have that predisposes them to all kinds of asthma. So if you have somebody with asthma, you know they're at high risk for anaphylactic shock because they probably have allergies. Okay? How do we treat anaphylactic shock?
Anti-inflammatory.
Epi. Okay, so that is the causes and the treatments of shock, and then I'm going to do a different video on signs and symptoms and whatnot.